This is so exciting for me. I would like to say that I feel like Dr. Nwando is a friend of mine, and I'm glad to have her on today. I'm so pleased to introduce her. She's been a supporter of our work group since its very inception. Dr. Nwando is a family physician, a public health professional. She's chair and professor of the Department of Family and Community Medicine at Ohio State University, Wexner Medical Center. Dr. O, there's so much we can say, but I'll make it brief in that she specializes in comprehensive care of patients from birth until geriatrics. She has an interest in providing care to patients who are underserved and marginalized. And this is really our theme of today, providing access to care in a time of crisis. Dr. O is an international advocate for women's, adolescent, and minority health, prevention of illnesses for people across their lifespan, addressing social determinants of health. She believes that healthcare is a right for all and not a privilege. So I'm going to let Dr. O speak to these themes today. We're so proud to have her speak to our theme this year. And with that, Dr. O, I will hand off to you. I'm going to stop screen sharing and allow you to share. So go ahead. And you are muted, so let's unmute.
Thank you. Yep.
Great.
Thank you so much, Libby, and everyone for inviting me here. I'm very, very excited to have the opportunity to address you. This is a meeting that I enjoyed coming to when I was in California area. So I'm super thrilled that you invited me back. So I'm just going to pull my screen out. Give me 1 second to get my slides up for you. All right. So I'm excited to speak with you today, and what I'm going to share with you is what I believe is a moment when technology became social justice, and I'll explain that as I go through the conversation with you. But really going to talk about the convergence of telehealth technology and social change, honestly, today. So looking forward to this conversation. So I want to start off by saying that as long as I can remember, I have been working in the area of anti-racism, anti-oppression, anti-bias in almost every single thing that I have done. And so these issues and this word cloud on the screen just highlights a number of different problems that have faced our society for as long as I can remember. And I've penetrated every single place that I've worked, every single activity that I've done, really since I've been in school. And so are kind of always in the back of my mind are the challenges of these things that are here on your screen. And so I think that my commitment to diversity, health equity, inclusion, community health really has been longstanding. And I've been fortunate enough that I would say my career has kind of come full circle. I started off as a medical student doing a lot of advocacy work through leadership in the Student National Medical Association, then went on to do my formal training in a residency at Columbia in New York, where I got really good immersion in underserved community medicine. Then got to do a fellowship in minority health policy and health disparities and an MPH at Harvard through the Commonwealth Fund program. And then had the opportunity to lead a national, do some work nationally, but at a federally qualified health center, Connecticut's largest one, Community Health Center, Inc. Moved on to UCSF, where I met Libby and many of you, where I got to direct the Center for Excellence in Primary Care. And then from there, went on to Rubicon MD, where I was able to work directly in an organization that was doing so much work around eConsult, which I'd become such a fan of and a pioneer for earlier on. And then found myself back where I started at Ohio State just about a year and a half ago. But in every single place, in every single role that I've had, that theme around health equity has been very, very prominent. So I want to talk today about social justice a little bit. And as I've been thinking about this talk, a lot of what I was thinking about is how do you make sure that we think about social justice, not as something that's disconnected and an important thing for someone out there to focus on, but how do we focus on it in the work that we do every day? And I've been thinking about what are the essentials of any really good social justice movement. And as I've been reading more and more about this, there are 4 key things that make up a really good social justice movement. That includes access, equity, rights, and participation. And for most movements that we know of, whether they're for civil rights or women's rights or LGBTQ plus rights, those things are the core things that people are looking for: access, equity, rights, and participation. So when I think about 2020, this has been such an interesting year for all of us. in many ways, we have struggled with our own realities, and we've learned a lot about ourselves. And I think that's the good, but we've also uncovered a lot of problems that have been there for quite a long time. And so we had this combination of this deadly virus and also the viral video. And I think the combination of having a worldwide pandemic that gave us time to really pay attention when we saw and witnessed the tragic murder of George Floyd, really set off this tension where people started to say, what is my role specifically? You know, this social justice is not something for people somewhere else. It's not just for people that have a lived experience, it's for everybody to engage in. And as we started to see the pandemic unfolding, we all saw these really staggering and shocking social inequities that emerged. Now, I say shocking because for many people, this is the first time people had actually realized that these disparities existed. Now, for many of us that have been in public health and in the health disparities world for a long time, we could have expected this to happen. But when you mix, a pandemic with people that, live in crowded housing situations, they have close physical contact, they're essential workers not able to get out of their work environment, have prolonged exposure. We saw significant disparities in cases, hospitalization, and death between white populations and minority populations in this country, in particular when you added on other elements like poverty or other forms of social distress, you had a recipe for COVID-19 to be a complete disaster in many communities. And what we saw is, and these are a number of different really interesting analyses that have been looking at that relationship between social determinants of health and healthcare. And in the places that we saw in Central Ohio, where we had the highest number and the worst outcomes from a number of different chronic health conditions, so that health convergence. We also saw when we started to look at opportunities, so what are the opportunity challenges, places where there's a lot of opportunity for growth and economic prosperity and places where there's low opportunity. We saw this real interesting connection between these four things. So where we had very, very sick patients in our communities with low opportunity from overall economically, low health opportunity, they ended up being the communities that were the highest in the terms of social vulnerability. So it became imperative to think about how do you manage what you've already been managing, which is really big challenges in health and healthcare disparities, but also this complexity of social vulnerability that's been added by the different things that COVID has laid in front of us. And then we had this massive government shutdown, we had states shutting down, we had all these different challenges where all of a sudden, now you've got people that are at home. We had at least 1 billion students that had to stay home because of school closures. But we also saw challenges that happened with not just the kids that went home, but families and working people all over the country, all over the world. And soon enough, as we could have expected, people who were essential workers started to relay their difficulty in getting access to a number of things, including the ability to pay for the things that they normally do, that they'd either fallen behind on paying for things or having difficulty being able to manage their regular household expenses, given what happened with the pandemic. And this situation also worsened a problem that we had not necessarily been totally prepared for. On this slide, I'm sharing the work of PACT, which is Partners Achieving Community Transformation, which is Ohio State's nonprofit community partner that does a lot of work in building community engagement and community partnerships across the Near East Side of Ohio, which is Central Ohio, which is one of those places on that index that I showed that was highest vulnerability and worst health outcomes. Now, some of the work that they were doing during this period was trying to figure out as people were getting work sent home, their children were getting sent home, they were losing their jobs and their roles, what kind of access did they have to the internet and what were the barriers to being able to use the internet in their houses? And they went door to door, knocking on people's doors, trying to figure out what they had so that we could figure out what we needed to do to respond in this moment. We found that a very low number of households had laptops and smartphones, under 30% for both in these communities. And many of them that did have those did not have reliable fixed internet. So if you add up folks that didn't have reliable fixed internet, that didn't have internet at all, we had over 50% of the members of the community that we went to that were expressing these concerns. And one of those big concerns was that the cost was a primary barrier, and some of them didn't know about any subsidies or other things that could help them. And also some of them didn't actually have software and hardware tools that would enable them to access. So this was a really important piece of information. Then another thing that we've seen is that, this is from the Kaiser Family Foundation, that a number of people in our country lost jobs. And so thinking about many people that are covered by employer-sponsored insurance, expecting to have about 27 million people that became newly uninsured due to the loss of that employer-sponsored insurance for whatever reason that happened during this pandemic. And so we had this situation where you have people that are not able to avoid the situations that put them at risk, may or may not have insurance that will cover them if they are at risk or if they're infected. And it just was this spiral of a vicious cycle. And so in this really interesting op-ed by Fareed Zakaria, he talked about the pandemic really upended our whole present, but we do have a really important opportunity that we can use to remake our future. And not that this is anything new to all of you, but there were forces that were already gathering steam, and this crisis just accelerated a number of them. And he asked us to think about what are the changes that we have accepted in our own lives in response to this pandemic. We agree to isolate ourselves for long stretches. We're working, attending meetings, having deeply personal conversations like the panel you all just had by talking through our laptops, taking online courses and seeing doctors and therapists using telemedicine. So things that would have normally taken years for companies to change and policies that would have taken years took us a month to do things. Cities, were able to make changes massively. So there is, in the midst of this despair that I'm talking about, there is a lot of hope for our future. Because people still, regardless of any of that, they still need primary care. They'll still need specialty care. And as we saw earlier in the pandemic and what we're seeing now in our next wave of this pandemic, they still need that hospital care. So that remains true no matter what. So now we started to think, how are we going to rethink healthcare? What do we need to do? And we started pushing, and we had a massive effort through our Health Equity Steering Committee, our Center for Primary Care Innovation and Transformation, and a number of other groups at Ohio State, including PACT, the Partners Achieving Community Transformation, where we started saying we need to help people dig deeper into the communities, amplify the voices of the community members, get people out to vote, get people to be more uncomfortable with their present situation, and really start to help people that needed things that they had not previously needed, and help realize where there are opportunities for us to make a difference, leveraging technologies and thinking beyond healthcare. And I talked to those fast because I'm going to hone in on one of these here. So back to this social justice core. As we talked about, social justice, a good social justice movement, and something that is really trying to gain impact and steam in the social justice area will need access, equity, rights, and participation. And I'll argue that as we've been looking at this COVID-19 pandemic, that technology really became social justice. And for each of these different domains of social justice, I want to share a little bit about how technology has been helpful during this moment. So the first thing is around access. We've seen technology, I'm talking specifically in healthcare, be an enormous enabler for getting clinicians to consumers to have direct care with each other, for having our clinicians be able to engage with patients as they're giving hospital care, bedside rounding with iPads, and just different ways of communicating, calling patients, family members at home to be able to see their family member in the hospital when we had restrictions, expanding the use of home monitoring and remote tools for patients to have access to their clinicians and for clinicians to have access to them in new ways. And also electronic consultations where clinicians had to still connect with one another because the patient's needs did not go away, even though we had all these other factors in our environment. So in our department, we, as many of you pricing, we had to, like everyone else, rapidly try to figure out how we were going to get ourselves into widespread use of telehealth, going from very low pre-pandemic levels to very high pandemic surge levels. Really just an enormous testimony to the effort of so many people on our team, but also a number of other factors that allowed this to be true. And we've seen and continue to sustain pretty high levels of telehealth adoption since that time. And we're talking on going from very small number of video visits to 20,000 in just a few weeks, and really seeing remarkable uptake of electronic visits, telephone visits, and video visits for our patients in the primary healthcare setting. Now, we also interestingly realized that we could do a lot more with telehealth than we had probably realized before. And so if you take a look at this on the right side is just a number of different procedure codes for some of those telehealth visits that we had. And what we're seeing here is that it wasn't just kind of the routine clinical visit, but even some more complicated visits and psychotherapy and nutritional services and preventative care, all of these things we realized we could actually really do them pretty successfully and safely via telehealth. Additionally, as I mentioned, we also still needed specialty care. And, as the primary care practices were closing, specialty practices in our environment were also closing. We were worried that we were going to have massive dips in our ability to get access to specialty care. But thankfully, we had eConsults, and we had eConsults already. And we had a really good mechanism through which we would connect with our specialists within our network. And so we were able to see pretty much a steady level of eConsult use, even during the surge, rather than a dip that many people experienced in access to specialty care, because we were kind of primed to be able to do this. So that was a really good positive outcome of this experience. The second part of that social justice core is equity. And so we've been doing a lot of work here on empowering community health workers to do outreach using different tools and some clinical decision support that we provided when we can recognize that there might be patients who could be at risk for COVID-19 or be at risk of falling sick from other things in the period of COVID-19, and empowering those community health workers to use that technology to reach out and do some really targeted outreach. Focusing a lot on tech equity or techquity. How do we make sure that we are providing technology access and technology-enabled services for people all over that social spectrum? Teaching telehealth literacy to our communities, and a lot of focus on bridging that digital divide. We saw our role as we are thinking about how do we take care of our patients who are going to be at home or who are going to be communicating to us, not in our clinics anymore, but how do we also, what is our role in teleeducation and making sure that children in those same homes are still able to learn when they got moved? So we were really thinking a lot about both teleeducation and telehealth. And so in a lot of the work that we were doing through Digital Divide, we started to describe different strategies that we thought would be powerful and useful as we started to move towards more equity in healthcare. And we worked on 5 really important strategies. One was really trying to accommodate in the technology environment and the telehealth world, patients with language literacy issues or disability, and making sure that we were able to think about all the different needs that patients from different backgrounds and different sets of needs would have. We also been working on broadband expansion. I'll mention that in a moment, because we recognize that for our patients to be able to effectively get care by us, and for us to be able to understand where they are and use the remote monitoring tools or even the teleeducation piece, we needed to really make sure that our patients were situated with good broadband. Also engaging our community health workers in different ways, figuring out ways to provide very focused telehealth literacy training, and also training our clinicians in a new way of thinking about the webside manner if they were not going to be at the bedside. And what does digital empathy look like in a setting where you are taking care of patients in this new way? So back to PACT, who I mentioned earlier. So part of what they have done in this program is thinking about telehealth and teleeducation. They started to pilot a program through a Smart Columbus city partnership where they could get people access to internet for $15 a month. Then we also started distributing iPads to residents in one of those high vulnerability zip codes that I showed you earlier. And then partnering with a number of different organizations, including our Columbus Metropolitan Library, some of our local architects, and our digital initiative called Columbus Rising Project, to actually provide digital literacy, telehealth literacy, teleeducation literacy for our communities that were most at risk for being marginalized and left behind during this moment. And then the final thing at that core is about rights. And so how can technology really help us in rights? And so we as Libby mentioned in my intro, I feel and have felt very strongly that healthcare is a human right. And, figuring out how do we leverage technology to make sure that we help people to access and tap into their rights, their right to civic engagement, their rights to health, and what kind of legislative change can we use to drive some of those rights and health policy reform. Well, again, we were fortunate in this moment that we saw a lot of activity that enabled us to get this right. One thing was the relaxation of HIPAA restrictions that allowed us to have interactions with our patients through various social media applications and software. And so not having to use only our electronic health records, but also having access to things like Zoom and Skype and being able to use those safely with our patients. Also, CMS made some changes where we were allowed to have provide care across state lines. So what if, patients had traveled somewhere else, but then they're trapped in another state because they can't travel at that time, and being able to actually continue to provide care when the patient and the physician were no longer necessarily in the same state. We also saw some fantastic adaptations from CMS, again, around reimbursement parity and making sure that we thought and recognized telephone visits and video visits as the same way we did in-person visits during this moment. Being able to still provide access to new patients to be able to see us was a huge, huge legislative policy victory, I think, because if you don't have access before a pandemic and you weren't already established with someone, that should not mean you would not have access to become a new patient. So being able to relax some of that legislation around new patients. And then also kind of expanding the list through CMS of the telehealth services that could be covered in this. So the right to a technology-empowered care was really propelled and fueled by a number of different legislative and policy changes. And participation was really important as well, because as patients started to engage in this, we needed them to also think about what is their role in their communities, and how do they become brokers in their communities? How do you empower people through technology? And then we also were thinking very much about technology-enhanced civic engagement. So here, I just want to share something really, that we were very proud of. We had set a goal in our primary care settings, and then expanded to our emergency department settings and our specialty settings, that we wanted to have, before the elections, we wanted to have at least 5,000 patient conversations done with patients across our medical center. We did that because we felt it was very important. Many of our patients do not always have access to information about civic health and that connection between civic health and health care. And we felt it was really important that we started to empower our clinicians, our staff, to be able to have these conversations with patients. And so we created what we call the Technology-Empowered Voter Engagement Toolkit, where some of our family medicine residents in my department created a voter advocacy video to help patients understand what voter advocacy means. What do you do? How do you register to vote? Where do you do it? How do you do it during a pandemic when we have all of these other challenges that are in front of you? We also had members of my team created scripted talking points for us to have these conversations with our patients and with our community members at any point of care. So it could be a revenue cycle specialist, it could be a front desk staff member checking in the patient, a medical assistant, any of our clinicians being able to actually have these scripted talking points for them. We also created a number of system-wide smart phrases in IHIS, which is our integrated health information services with Epic, in which we were able to document those conversations. And then we asked, if patients didn't have access to do some of these other things immediately, they could scan QR codes that would help confirm if they were registered to vote. It would give them guidance and information on safe voting practices and any other information that they needed around the vote. And we were able to do those very easily, even through our telehealth visit. So we could hold the QR code up to the screen, patient could hold up their device, and we'd be able to get them connected. And this is a brief snapshot of what we saw with that. That we had about, a lot of patients scanned those codes and they were able to get registered to vote or get absentee ballots or to track their ballots. We had a lot of people that watched our voter advocacy training video. We held a forum with Vote Health 2020, which is a nonpartisan group of physicians and other clinicians that have come together to really bring out the vote this past election. We documented almost 1,800 conversations in IHIS using those smart phrases, and we were able to get messages out to 370,000 patients in email to talk to them about voting, and we saw a number of them open those and also go to the Vote Ohio website and also go to the census website. And so we really saw a lot of civic health advocacy and engagement through kind of thinking about how do we use technology as a tool for social justice. So, as I close, I just want to say that, before this, I've been really, really excited about technology-enabled care, technology-enabled access to care, but thinking about technology as social justice has been really fascinating for me over these last few months, and really, really thrilled that we've been able to actually create meaningful change in the communities that we're in. But we have to really sustain and keep our feet on the gas and think about how do we want to make sure that the system that we have designed in the pandemic, whatever's working with it, let's try to really keep it going. Whatever isn't working, whatever we've realized is a challenge still, let's try to fix it. And so what am I asking for you all to do? And how can you be involved? And you are all doing such great work already. And so, but the things that I'll say is that we need to continue to advocate for that telehealth parity, for in-person care in CMS and across all payers, because we realize that a number of patients really have enjoyed the benefit that telehealth has brought them, and has allowed them to be safe and has allowed them to have really meaningful relationships with their primary care providers, with their specialty care providers, even when they're in the hospital. We also need to have you urge the ongoing health policy changes. We've relaxed some HIPAA related restrictions and state licensure restrictions to be able to create care opportunities for our patients, but we need to continue to have those conversations so that we don't go backwards and back to a time where none of this was really accessible for any of our patients. I can say personally that my patients that I take care of are really, really thrilled about the opportunity to have telehealth as an option. Now, for some of them, they really want to come in and they feel like that's fine. But for others, and for most of mine actually, they really do like this other option. And I think continuing to allow patients to have the choice is really, really important. I also think it's really important to expand access to eConsults because specialty access to care barriers grew significantly. And we know for sure that eConsults have and have always been a huge and important investment in being able to get access to specialty care for the communities that are most underserved. And so continuing to push for more access to eConsults, for reimbursement around eConsults, and to just make it really a standard part of our practice. We see that it will still be used whether there's a pandemic or not. And so I just want to continue to urge that we push for that. Also, like creating opportunities in your environment for patient telehealth, digital literacy training and support. We can't really assume that people understand how to have these relationships through telehealth related encounters. It's not something that everyone just understands how to do automatically. And so thinking about how do you teach people how to engage in this way, in a different way. And I love the work that our PACT group is doing, literally going door to door. Now we're distributing iPads to folks, and then also helping them understand, do you know how to log in? Do you know how to set up your MyChart? Do you know how to do these kind of things? And really making sure that someone is providing that support through our community health workers. And then finally, partnering with community organizations like what I described with PACT, but there are also so many others that are probably in the environments that you're in, and think about how do you play a role as a healthcare provider or payer or institution, or someone with a healthcare vested interest. How do you use those partnerships to expand access to the things that are ultimately going to be essential for patients to have access to you, which is software, broadband, hardware for rural and urban underserved communities. And I think we, together, if we can do all of these things, we can do the things that are right and take and really catalyze the things that have worked, and really make sure that we don't go back to a stage where patients lose choice, lose access, and lose opportunity. So, closing, technology is social justice. And I think about this when I think about my own children who I, had the, great fortune of being part of a lot of the responses that I've been part of. And I know that they're watching and they're paying attention. When I think about my two kids, obviously kind of participating in some of the social justice movements, participating in the mask distributions that we did for COVID and our response. I think about their education, going home and being, having to school from home. I feel like if my kids can and have access to the software, the broadband, the hardware, the literacy to be able to be part of a teleeducation model, or if they need to have healthcare visits and they have access to that model, whatever we would do for them, we should be doing it for the communities that we take care of as well. And so it's all for them. And I hope that everybody, as you are thinking about your work, you remember that it's not really meaningful to us if we have all that we have and those that are around us in the communities that we take care of don't. So thank you all for your time, and I'm open to taking any questions and comments.
Yes, thank you so much, Dr. Nwando. I have a question. I know some others may be coming in, but I want to take us back to a few years ago when you were with us speaking about patient engagement in eConsult. And I noticed on your last slide, you said, think about opportunities to help patients with telehealth literacy. And your presentation a few years ago was surprising to me, how eager patients were or interested and happy they were to be receiving eConsults. Can you give us advice as to what you would say to patients who may not get this? This may not seem second nature to them, but as a provider and as someone who is a user of eConsults, what do you say to patients to help them with this?
Yeah, well, so interestingly, for my patients in particular, they all hear about eConsults as the first thing I'm going to do before I send them anywhere, because I'm already a believer and I already feel very strongly about this as a way of access. I actually am really surprised and glad that so many patients were very, very accepting of eConsults during the thing. I mean, people didn't want to go anywhere. Like, can you actually, actually having patients request a way to electronically connect to the specialist, as opposed to me kind of imposing it on them during the pandemic and saying, like, is there any other way that you can connect me to specialists? Do I have to go in, or do I have to, go in person? And so I feel like that was the really important opportunity where it started to become something that patients asked for. And only when it really was not possible, then you couldn't do it. But for the most part, people were really accepting of it. So I think the conversation is really around how do you keep people safe, right? And so, I mean, my eConsult kind of narrative has definitely evolved over time. I mean, obviously, it's initially just about access, but in this moment, it's also about safety, right? And making sure that you're not exposed or further at risk. And also being really confident that when we do make that eConsult, you're going to get the best care, and I'm going to be in a position to make sure that I get that information back to you, and whatever we need to do, we'll be able to get it done. And so I think just constantly reassuring people about that model, and in my mind, making it the first pass, like Delphine and folks have done already, like make that the first pass to entry to we're not quite there yet, but I think making that just the way you start off engaging with the specialist is the way to do it.
Thank you so much, Dr. Olayiwola. Just wanted to say how much we appreciate the inspiration. I think this is a hard time for so many of us, and you really take in what are challenges that we're all facing and made them really inspiring to us. So I love seeing the pictures of your kids, and the kids are where we get our hope. So thank you again.
Yes.
We appreciate your time, and we know you took your time away from your patients. So I know you're probably heading back to see those patients now. Many compliments floating in, and if we have any other questions coming in, we'll share them with you offline.
All right.
So thanks again for your time.
Thank you, and thanks for your great work.
Thanks.
Take care, everyone.